Hi everyone, thanks for listening to my presentations. Today I'll be talking about hepatitis B virus infection. I'll be limiting myself to only the diagnosis. Vaccination and immunity. I've decided to bring this out first because if you have been vaccinated and you want to be sure if you've built immunity or not, all you need to do is approach your doctor and they will ask you for the antibodies to hepatitis B surface antigen. So, in vaccination and immunity, you will only have anti-HBS or anti-HBsAg. I will take you through certain terms because we are going to come across them in the course of this presentation. Hepatitis B surface antigen means we are dealing with current infection or chronic hepatitis B virus infection, and he or she is infectious. When hepatitis B envelope antigen is positive, then it means we are dealing with active viral replication. When hepatitis B core antigen is positive, it means we are dealing with active viral replication and the individual is infectious. When it comes to hepatitis B virus antibodies, anti-HBc means hepatitis B core antibody, and that will be pointing to past or current hepatitis B infection, and it will persist for life. Anti-HBsAg means anti-hepatitis B surface antigen, pointing to immunity, either recovery from past hepatitis B infection or vaccination against hepatitis B. IgM antibody to hepatitis B core antigen will be pointing to less than 6 months infection, meaning the presence of acute infection. Who should be screened for hepatitis B virus infection? I have placed the pregnant women here as number one set of people, and we have to screen them in each pregnancy at the very first antenatal visit. You can check my channel for the first antenatal visit full presentation that has been published for a while now. So check my channel for that, please. Also on the list of the people to be screened for possible hepatitis B virus infection are immigrants and adopted children from high or intermediate prevalency area of the world, like Mediterranean and Asia and Africa. Also, transplant recipients or other immunosuppressive requiring conditions should have hepatitis B virus screening. Why that? Reactivation is possible, particularly if there is hepatitis B surface antigen positivity. Also, amongst the people to be screened are organ donors. And why that? To prevent transmission of hepatitis B virus to the respective recipients of their organs. Also, blood donors in case of blood transfusion to prevent transmission as well. Semen donors should not be spared so as to prevent possible transmission via that means. Plasma donors should be screened to prevent transmission. Newborns of hepatitis B virus infected mothers should within 12 hours of life be given hepatitis B immunoglobulin and hepatitis B vaccine start. Then they should continue with hepatitis B vaccine again at 1 month and at 6 months. Then we'll have post-vaccination serology, and that should be done at 9 months to the 12th month of life. Also, among those that should be screened will be sexual contacts of infected person or persons. Household contacts of infected person or persons should be screened. Heavy drug users and anyone with sexually transmitted infection or otherwise known as sexually transmitted diseases should be screened. To those who will be honest enough to own up that they have multiple sexual partners, they should be helped by screening them for hepatitis B virus. Homosexuals should be screened as well if they volunteer the info. Also, inmates in prison should be screened for hepatitis B virus. People with liver diseases or HIV positive patients should be screened. And why that? If you have listened to my presentations, you will discover that when I was talking about symptoms, fulminant hepatitis and acute hepatitis B virus is possible in people with underlying liver disease or another viral infection at the same time with hepatitis B virus infection. So if we know that this is someone with liver cirrhosis, it should be screened for hepatitis B virus. Or this is someone with HIV or cytomegalovirus or Epstein-Barr virus, should be screened for hepatitis B virus. Hepatitis C virus infected people should be screened for hepatitis B because that will lead to severe hepatitis if we have hepatitis B virus co-infected with hepatitis C virus. People with end-stage renal disease should be screened for anti-hepatitis B virus every year, and they should be given hepatitis B virus immunoglobulin if the outcome of the screening is less than 10 milli-international units per ml. We are still on the list of those who could be screened for hepatitis B virus. Those with signs and symptoms of hepatitis A, hepatitis B, hepatitis C, or hepatitis D that could not survive without hepatitis B should be screened for hepatitis B virus. Diabetic patients, because immune suppression will worsen the situation if they should have hepatitis B virus infection, they should be screened as well. Health workers who could have been exposed to hepatitis B virus should be screened. For example, nurses, cleaners, and doctors with needle prick should be screened and be given both immunoglobulin and vaccine if the status is unknown. Sexual assault victims should be screened for hepatitis B virus infection. Staff and residents of mentally challenged individuals should also be screened. In acute phase, we might be dealing with hepatitis B surface antigen positivity and IgM hepatitis B core antibody. Initially, the marker for hepatitis B replication will be hepatitis B envelope antigen and hepatitis B virus DNA. Recovery will be accompanied by the disappearance of hepatitis B virus DNA, and will now be dealing with anti-hepatitis B envelope zero conversion from hepatitis B envelope antigen. Hepatitis B surface antigen will be zero converted to anti-hepatitis B surface antigen. Fulminant hepatitis B. Sometimes in fulminant hepatitis B, the hepatitis B surface antigen will be negative, but Antibodies to hepatitis B surface antigen has not occurred. Why that? The whole situation is very rapid, right? So there will be very rapid conversion, and therefore we are left with hepatitis B virus infection that could be detected only with the aid of IgM hepatitis B core antibody. If hepatitis B surface antigen is positive, then the possible differential diagnoses are acute hepatitis B virus, exacerbations of chronic hepatitis B virus, reactivation of chronic hepatitis B virus, superinfection of hepatitis B virus carrier with A, C, D, or E, or hepatitis B virus carrier with acute hepatitis secondary to drugs and other toxins. If it is all about previous hepatitis B virus infection, then we'll have the history of it. Then we will be dealing with anti-hepatitis B surface antigen, okay? Antibodies to hepatitis B surface antigen. Then we'll have IgG hepatitis B core antibody. But if it is immunity after vaccination, all we're going to get is anti-hepatitis B surface antigen. No IgG hepatitis B core antibody. No. Chronic state, we give a clue about hepatitis B surface antigen that will be persistent for greater than 6 months. Hepatitis B virus replication will be evident by the level of hepatitis B envelope antigen, the serum hepatitis B virus DNA, and we want to know the value of ALT, and with that, we want to know how much of the liver has been damaged. So, ALT is necessary because of knowing the possibility of antiviral agent and to determine the level of liver damage. In chronic states, we will also do the following. We have to take thorough history, thorough physical examination, family history of hepatitis B virus infection, the history of liver disease, or hepatocellular carcinoma. Also, we'll add to the lab. In chronic state, we want to know what complete blood count is all about. Platelets, ALT, bilirubin, alkaline phosphatase, though not specific, but it is helpful here. Albumin, of course, INR or PT, which means we are not doing liver function tests and liver enzymes with complete blood count. Also, in chronic state, we want to know about hepatitis B virus replication, and that will take us to get the assay of hepatitis B envelope antigen, anti-hepatitis B envelope, hepatitis B virus DNA, other viral infections like antibodies to hepatitis C virus, antibodies to hepatitis D virus, and antibodies to human immunodeficiency virus. We have to screen for hepatocellular carcinoma with ultrasound or liver biopsy. Follow up. Let's get this clear. It's not everybody that will need treatment, and it's not everybody that will place on follow-up only. Who will qualify for follow-up only? Individuals with hepatitis E antigen positivity, but with hepatitis B virus DNA that is only greater than 2,000 international units per ml. And when ALT is acid, it will be within normal range. And when we screen for liver cirrhosis, there will be no liver cirrhosis. So while following up, we'll be doing ALT every 3 to 6 months. and hepatitis B envelope antigen assay every 6 to 12 months. If results are back and we are finding that ALT is raised, then we should assay the level of ALT more frequently, from 3 to 6 months to every 1 to 3 months. And we'll repeat hepatitis B envelope antigen every 6 months. If ALT is persistently raised for a long period of time, then we must have liver biopsy. Or if this person is greater than 40 years old, or there's positive family history of hepatocellular carcinoma, then we have to screen for fibrosis. And if the result of the screening for fibrosis is bad, we must commence treatment. Follow-up ends there, treatment starts. And during treatment, we'll continue to assay for all these parameters and more. Hepatitis B envelope antigen is back and is negative. Then we'll assay for hepatitis B surface antigen, because that can distinguish inactive carriers from hepatitis B envelope antigen negative chronic hepatitis. Those who are hepatitis B envelope antigen negative could be carriers if there's decreased ALT, decreased hepatitis B virus DNA, and then we'll be dealing with a good prognosis here. There's no need of antiviral treatment. But every 3 months, we must have ALT assayed. If ALT is increased, then we have to check for hepatitis B virus DNA. We want to know whether replication is going on. And we must test for hepatitis C virus and hepatitis D virus. How can we know that there is an occult hepatitis B virus infection? Hepatitis B virus DNA will be detectable using polymerase chain reaction, but hepatitis B surface antigen will be negative. Maybe seropositive for antibodies to hepatitis B core antibody. Polymerase chain reaction mostly will show decreased hepatitis B virus DNA in many, and the reason for decreased hepatitis B surface antigen as well. Hepatitis B virus DNA is often detected in the liver. Transplantation of liver with the above can lead to hepatitis B virus infection, which means transplantation of liver with occult hepatitis B virus infection can lead to full-blown infection in the recipient. Those with hepatitis B core antibody are prone to reactivation in the face of immunosuppression. Occult hepatitis B virus infection is associated with chronic liver disease, particularly in cryptogenic chronic liver disease. There's likelihood of increased hepatocellular carcinoma, more likely in those with chronic hepatitis C virus co-infected with hepatitis B virus. With that, I've come to the end of this very presentation. The next presentation will be on the treatment of hepatitis B virus infection. Thanks for listening. Remember to share. Remember to subscribe. I appreciate it.